A couple of questions. One, why do you think in the face of this data, the popularity of sleeves is so high? It would certainly seem, at least in the diabetic patients, that a gastric bypass would be a more durable procedure. Do you think it's just because the sleeve is easier technically to perform, or do you think perhaps the data isn't as well known amongst surgeons performing these procedures? Do you have any thoughts on that?
Yeah, I think part of it is that it just simply is easier to perform. I think surgeons tend to lose a little less sleep after doing a bunch of sleeves than they do after gastric bypass. It's certainly a nice fit for a lot of patients. And then there's the other school of thought that we'll just do a sleeve gastrectomy on everybody and see what washes out. And then, a couple years later, if you need better glycemic control or metabolic control, well, you have options. You can convert them to a bypass or a switch. And I think that's kind of in everybody's back pocket when they do a lot of sleeves, even on these metabolically challenged patients, is that they've got a backup plan if they need it, but there's a chance they may not. So they go ahead with the sort of less worrisome operation or less sort of morbid operation.
Are you seeing an increased number of sleeve revisions in your practice now from a sleeve, say, to a bypass or a switch?
I wouldn't say there's an increase. We have a subset of patients that we take care of who we intentionally stage, these BMI 75 plus men who just need to get walking again and moving and getting healthier before they can undergo a switch or a bypass. But for the most part, we're probably about 60-40 bypass and sleeve in our practice still. So we haven't swung quite as far as some practices are in terms of the sleeve. But honestly, I'm not seeing a lot of folks with sleeves coming back. The one thing I see the most that I've had to revise the most is probably some reflux-related issues. That's the main indication that I would convert a sleeve to a bypass for. But in terms of weight recidivism, I don't think the jury's still out, I guess, at least in our practice, in terms of the numbers that are going to be coming back.
In terms of weight recidivism, what's your thoughts on the role of combination therapy, meaning a surgical procedure and then combined with perhaps a pharmacologic therapy on top of it? Do you see the benefit of two together versus either one alone?
Yeah, I mean, every patient that comes back, whether they're a sleeve or a bypass patient, if they've had some weight regain or struggling, of course, get them back in the program and tackle the issues that need to be tackled. But thankfully, we now at least have some medical therapy to offer with 2 and soon to be 3 medications on the market that can at least help perhaps with hunger control and help modify their behavior a little bit better. So yeah, I use those along with our bariatricians liberally when we have patients with weight regain.
Well, that's excellent. I certainly open this up to our panel. In the interest of time, we were going to have a 15-minute panel discussion. I think the talks have been excellent, and we've had a lot of questions asked and answered during the session. I don't know if the panel has any burning questions that they would like to ask one another. If so, please go ahead, and if not, in the interest of time, we can certainly end this current webinar. So, any questions from anybody about anything?
I just wanted to make a comment on the issue of revising a sleeve to a bypass. I think my approach has certainly changed when, 2 to 4 years ago, when revisions were routinely being covered with insurance, I often took the tack that, hey, what do you got to lose with a sleeve? If it doesn't work out, you can always convert it to a bypass. My experience over the last year has really changed my approach to one of you have to make this decision, telling the patients they need to make the decision with the assumption that they're going to get one paid or covered bariatric procedure per lifetime. And I think it's important to emphasize that to the patients, that while anatomically and technically possible to convert a sleeve to a bypass, financially, it may not be a viable option for many patients if insurance continues to ratchet down or reduce their coverage or revision.
That's a great point, Tim. Just to make it clear, I'm not a fan of that school of thought. I think you need to have a more thoughtful approach in terms of your procedure selection, and not just hit everything with the same hammer. But but I agree. It is challenging to get that second stage done, even in somebody who has, put a case for it. But, as a society, we're certainly trying to fight those one per lifetime procedure policies, but it's going to be an uphill battle, certainly in the next few years. But that's a great point.
Any other comments or questions?
Keith, thank you so much for leading this conversation. It's been great.
Well, I want to thank all of you very much for taking the time away from your families and spending the night with us. I thought it was an excellent discussion. Thanks to SAGES, and thank you all very, very much. Have a great
Thank you for inviting us, Keith.
Yeah, thanks for the invite.
Yeah,
Have a good night.
Take care.
Thank you.
Good night.
Good night.